So, good morning, Bernardo. What kind of case we are going to do now?
It's a cheap case with a patient, a 70-year-old patient, which arrived last week in our hospital for a non-STEMI. We did the coronarography and we showed the two total occlusions of the circ and of the RCA with a diffusely diseased calcific LAD. So what we are going to do now is to try and attempt a PCI of the LAD and the diagonal branch, which is a highly diseased vessel in a patient which has a high bleeding risk because she had anemia and she had problems with the hemorrhages which were operated, and then she still has some anemia which we need to investigate, but the patient is unstable, so we need to fix the LAD disease.
So, Bernardo, how are you going to approach this difficult artery? It seems very tortuous and calcific.
Well, actually, as you have seen, the main difficulties was to approach the two vessels, meaning the LAD and the diagonal branch. They were really tough to be managed by the guide wires. So now we're gonna see how the disease is, because as we have said before, this patient is very high risk in terms of bleeding risk. So we want to assess the lesion, how it is by means of OCT, and so we would like to spare the metal, at least if not totally, we would like to reduce the entire length of stents. So we're going to use a DCB approach with SELUTION DCB. So this is our initial strategy. Then now let's see if we are able to do it.
What about intravascular imaging? What kind of imaging you prefer in this case, this very calcific case?
Well, we have a pretty good experience with OCT because we can see very clearly the lumen and also the calcifications, and we have a good experience with it, so we're going to use OCT now.
Okay, so Ugo, as you have seen, we were not able to cross the LAD lesion, the very tight lesion, with a probe, but we were able to do an analysis of the diagonal branch and the proximal part of the LAD. So let's review this.
But as you said, Bernardo, the lesion distal to the diagonal on the LAD is clearly significant. So, and we know it's calcific too. So we don't need OCT there.
Yeah.
We need proximally to the diagonal, because we have to decide how long the LAD must be stented.
If stented.
If stented.
Yeah.
You are right.
Yeah, the lesion is
a
very
lot
tight.
Of calcium. Here
yeah, we have
a little bit borderline stenosis of
we
the
have
LAD.
a co-registration. We can. Okay, so we have this co-registration from the diagonal branch with a very calcific lesion. Okay. So what we aim to do, obviously, is to save the LAD, if you agree, because we have all of the collateral flow to the RCA. So this is a very important vessel. It's a fundamental vessel for the patient. But we also aim to save this big diagonal branch. And so we may decide to treat this part of the LAD with this tight stenosis, and then also the diagonal branch, but without touching this part of the LAD, in order to save
So
metal.
spot stenting, one on the bifurcation and one on the proximal LAD.
Yeah, or stenting or not, I would like to see how the lesion preparation is faring, and then we decide if to stent or not.
But if you are going to use a drug-coated balloon, I don't know if you can cross this kind of lesion. This one and the lesion.
Let's try. Let's give it a try. Yeah, we need to prepare the lesion first, and then to assess if the drug-coated balloon is able to cross. I have to say that SELUTION DCB has a very high trackability and deliverability. So this is not a very complex lesion for this type of device.
It's a sirolimus eluting drug coating.
It's a sirolimus coated balloon, which was marketed for the first time a few months ago. And it's a very good device. We need also to assess its clinical benefit with the ongoing trials. So we will see it, but the first studies are encouraging. Okay.
So the problem, Bernardo, is that this patient is a high bleeding risk patient, because this bifurcation would be probably treatable at best with a 2-stent strategy. But
I must say.
But if we want to avoid 2-stent in this patient, we have to try alternative strategies, such as drug-coated balloon.
From the literature point of view, I agree with you. Diamo 8, 10. But as per our experience, we have managed this type of lesions also only with DCB. Now the crucial time is now. Now we have to see how it is going. Because we have seen that we have so much of ischemia during the dilatation, because from this vessel, the entire heart of the patient is sustained. Okay.
Very interesting result. It's totally unexpected.
Not so bad.
Totally unexpected, judging the quantity of calcium which was visible at OCT. And also at angiography, of course.
Yeah. So
you want to try to treat everything with the drug-coated balloon?
We give a try?
Without this?
We give a try?
I think we can try. We can try, why not?
Ok, metti di là per favore.
So Bernardo, we will see if these very long inflections necessary for the DCB will be sustained by the impeller about the pressure.
Because, this is crucial. Yeah, we need to see if impeller is doing its job, because we have seen just with the normal inflation that the blood pressure dropped to 70.
Before it dropped after only 30 seconds of inflation. How long inflections we are going to perform with this DCB?
Well, we have to tell you, we have to go shorter than
30 seconds?
What is suggested. Shorter than 30 seconds.
Shorter than 30 seconds?
Yeah. Well, actually, the first preclinical studies show that also even less than 30 is enough, maybe enough to deliver. But now we want to save this heart. So now let's 12, 14.
And are you going to finish with the kissing DCB balloon, or
no,
we will inflate separately the two
We don't need
vessels?
it. I would say that we can inflate it separately, and then we assess if we have some plaque shift at the carina. So we did a 28 seconds of inflation, which is actually not recommended, because we usually try to be longer, even 1 minute or more. But in this case, in my opinion, it is not recommendable. Are we going to do a final OCT, or we prefer not to see?
I think if you perform OCT, then you are
obliged to
stent, because you will see for sure some dissection, some suboptimal
It will be more difficult to resist.
And we always said that after DCB, you have to be satisfied of a suboptimal result, because it's going to improve in the next weeks. This is a typical characteristic of drug-coated balloons.
Correct.
To have a suboptimal result acutely, and then to
have a gain.
A gain later.
Yeah.
So let's see first of all the angiographic result.
Are we going to do the angio, or we can stop here? Let's have an angio.
At least the angio. Okay. Let's do it.
Ok. Ci siamo? Vai.
Beautiful.
Yes.
Angio is beautiful. I don't want to do OCT.
Yeah, I agree with you, Ugo. Okay. Yeah, I like this. Also the flow, the collateral flow is much better. Then we have another thing.
It's improved the flow in the right coronary artery.
And we have not done any nitrate in the coronary, so this is important. And I have to see another thing, that we have that huge septal branch, which could be occluded if we implanted a stent there. And that is a very important branch for the patient. So I think I'm satisfied of the result.
I agree with you.
So, as a short clinical update on the patient, we wanted to keep for 1 month a dual antiplatelet therapy with aspirin and Plavix and go on with Plavix. However, the night following the intervention, patient experienced a bleeding, and so we had to stop aspirin and went on with Plavix. After 4 additional days, hemoglobin levels remained stable, so we were able to send the patient for rehab. Thank you for your attention. Bye-bye.